This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, C-311. Did you know live Senate video is now available at youtube.com/@Senate of Virginia. Senate Committee Room, C-311. This is the Senate of Virginia, Richmond, Virginia. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, C-311. Did you know live Senate video is now available at youtube.com/@Senate of Virginia. Senate Committee Room, C-311. This is the Senate of Virginia, Richmond, Virginia. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, C-311. Did you know live Senate video is now available at youtube.com/@Senate of Virginia. Senate Committee Room, C-311. This is the Senate of Virginia, Richmond, Virginia. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, C-311. Did you know live Senate video is now available at youtube.com/@Senate of Virginia. Senate Committee Room, C-311. This is the Senate of Virginia, Richmond, Virginia. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, C-311.
Good afternoon. The Health Subcommittee will come to order. Will the clerk call the roll?
Senator Favola,
Here.
Senator Sutherland,
Yes.
Senator Bagby, Senator Aird,
Present.
Senator Durant. You have a quorum.
Thank you so much. I know my colleagues have lots of other time commitments, so I'm expecting that they might be here shortly, but to respect everybody's time, the subcommittee is scheduled to start at 4 o'clock, and I felt we should go ahead and start since we have a quorum. The first patron to sign up was actually Senator Locke, and I don't see Senator Locke here. Is Senator Locke present and I'm missing her? She's not here? Okay. So I can do my bills, and then Senator Stanley is defending a bill in agriculture. So I am just going to go ahead and present from here. Mine are simple. Is that okay? Okay. All right. I'd ask the committee to draw their attention to Senate Bill 841. It is a recommendation from the Joint Commission on Healthcare. It's a Section 1 bill, and it directs the Board of Pharmacy in collaboration with DBHDS to develop and implement a process which opioid treatment programs can apply for and receive the necessary permissions and waivers to dispense opioid use treatment medications from a mobile unit. The Joint Commission on Healthcare had studied this topic. One of our goals on the commission is to really improve access to care and to keep care as affordable as possible. And hopefully we can get to the goal of improving the health of Virginians. So being able to treat opioid issues from a mobile health unit would be incredibly important and very needed for the mission I just described. Again, this is a process bill. A report would be due back to respective committees, actually to the Joint Commission on Healthcare, with the next steps on how to make the dispensing of treatments, opioid disorder treatment medications, a reality. So it's sort of the first step in the process. And I am going to ask my colleague, Senator Aird, to chair the meeting for a moment since I presented my bill. So, Madam Chair, I would ask that the bill be given positive consideration. I don't see anybody in the audience who might be in opposition to the bill?
Is there anyone in the audience in opposition to this bill? We're looking at Senate Bill 841. Seeing no one in opposition, we will now open it for a motion.
Thank you, Madam Chair. I move that the subcommittee recommend report of Senate Bill 843.
And I will second
841.
that. 841. It's been moved and properly seconded. Any questions, further questions?
That's right.
Let's open the voting roll to cast our vote.
Good catch, Madam Chair.
Senator Favola,
Aye.
Senator Suderline,
Yes.
Senator Aird,
Aye. I'll now turn the meeting back over to you, Madam Chair.
Senator Aird, I'm going to ask you to keep the
Oh.
mantle for another
Okay.
moment. I would like to present Senate Bill 843. This is another Section 1 bill, and it is also a bill that came out of a study by the Joint Commission on Healthcare. And this bill would direct the Department of Medical Assistance Services, DMAS, to develop and plan for expanding eligibility criteria under Medicaid for remote patient monitoring for individuals with chronic conditions. Again, this is a way of improving access, of helping individuals monitor their conditions. It's certainly going to help in enabling individuals to get to a place where they're healthy. Madam Chair, with that explanation, I hope it is the will of the committee to favorably view this bill. I am not aware of any opposition.
Thank you so much, Senator Favola, for presenting Senate Bill 843. Is there anyone in opposition or wishing to speak to this bill in the audience? Hearing and seeing no one, I will now open it up for a motion.
Madam Chair.
Yes.
I move that we recommend report of Senate Bill 843.
Senator Suderline, I will second that motion. It's been moved and properly seconded. Any further questions? Hearing none, I'll open it up for the votes.
Senator Favola,
Aye.
Senator Suderline,
Yes.
Senator Bagby, Senator Aird,
Aye.
Senator Durant,
That motion carries. Thank you so much, Senator Favola. I will now turn it back over to you, Madam Chair.
Thank you, Senator Aird. And Senator Locke has joined us. So welcome, Senator Locke. You have 4 items on our agenda, and we'll start with maybe the lowest number.
Ma'am, 3.
Oh,
not
you
4.
have 3. 1, 2, you do. 3 items. You are correct. Do you want to start with Senate Bill 758?
Yes, ma'am. Let's start
Okay.
with that one, which deals with remote patient monitoring for pregnant and postpartum patients.
Yes.
Okay. And Madam Chair and subcommittee members, despite advances in medicine and healthcare services, maternal mortality in America has increased 144% in the last decade. Mortality is disproportionately highest for Black women in the United States. According to NIH, mortality was twice as high in rural areas. In communities of color in rural Virginia, women are at a higher risk for a poor outcome in pregnancy. Much of this disparity is directly linked to women and families not having access to the preventive care and resources they need for a healthy pregnancy delivery and life with their loved one. Remote patient monitoring offers healthcare providers real-time information about their patients' vital signs and other relevant health data such as blood pressure, blood sugar, and oxygen levels, all important factors to track during and post-pregnancy. The Virginia Telehealth Plan currently guarantees Medicaid coverage of remote patient monitoring for high-risk patients. While this is an excellent start, this subjective standard limits many Medicaid patients from receiving the service they need to detect potential challenges during and following pregnancy. This particular legislation will allow providers to appropriately determine whether patients are high risk and need additional care and services. So specifically, SB 758 expands remote patient monitoring to all pregnant and postpartum women on Medicaid.
Thank
And
you.
if you need any additional information, Julie Dime with VHHA is here if we would like for her to speak.
This bill is in very good shape, so if all of you are in favor of the bill, we will take note.
Any opposition?
Move to report.
Second.
Ms. Dime, did you want to say something? Okay. All right. We really do like the bill, so we will save you the effort, although we do appreciate your interest in the committee. And a motion has been made by Senator Aird and seconded by Senator Bagby to recommend reporting the bill. Will the clerk call the roll?
Senator Favola,
Aye.
Senator Sutherland,
Yes.
Senator Bagby, Senator Aird.
Aye.
Ayes 4, noes 0.
Okay, we will recommend the bill reports. Thank you, Senator Locke. Next, you have Senate Bill 831.
Yes, ma'am. And there's a substitute for this particular bill.
Okay. Okay, this is a Section 1 bill, as I see it.
Yes.
Okay. I'd like a motion to accept the amendment.
moved.
Okay. We accepted your amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Okay, the amendment's before us. Go ahead.
Okay. This particular bill deals with presumptive eligibility, and hospital presumptive eligibility for certain groups, and pregnant women are included among those groups under the ACA. And HPE allows coverage from the date that a qualified provider does the screening through the last day of the following month for a maximum of 60 days. The scope of coverage is limited to basic needs, including outpatient hospital services related to prenatal care, prescription drugs related to prenatal care, as well as emergency services, x-ray services, lab services, physician services, and so forth. And according to America's Health Rankings, Virginia ranks 19 worst for clinical care, and a key component of this ranking is access to care. Presumptive eligibility will improve access to care, and that is the sole purpose of this legislation.
And the presumptive eligibility is allowed under our current Medicaid plan. Is that correct, as I understand that? Or do they have to seek federal authority to implement presumptive eligibility, right?
This is for presumptive eligibility for ambulatory prenatal care for pregnant women.
Right, but we would have to petition the federal, I'll ask General Counsel, we have to petition the federal government, CMS, to get this authority. That's my question.
Yes, Madam Chair. If you refer to the substitute in front of you, you'll see lines 9 through around 11. It directs DMAS, Department of Medical Assistance Services, to seek the necessary federal authority to implement preemptive eligibility for pregnant individuals. And then if federal authority is authorized to do so, that's when the Section 1 bill directs DMAS to authorize the listed qualified entities to make determinations of presumptive eligibility for pregnant individuals.
Just a follow-up question. How long does it normally take to get permission from the federal government? Let's say DMAS is ready to go quickly after this bill becomes law. Then this process has to be set into place. How long would that normally take?
Madam Chair, I cannot tell you for certain how long that takes. Typically, it does have to, like you said, it does have to go through the federal government. They can typically submit these amendments and requests throughout the year. I'm not sure if anybody knows if there's a typical time frame for that in which it can be expected.
Mr. Frank, are you here to speak on behalf of DMAS? We just want to fully understand the process because we do like this bill. I feel confident we do.
Yeah,
Yes.
absolutely, Madam Chairman, members of the committee. I'm Sarah Cariano with DMAS. So it is a state plan option, so that means we'd have to prepare that paperwork, submit it to CMS, and they have to approve. It can take 6 months. They have 90 days once it's submitted to either approve it or basically send it back to us for additional edits. Hospital presumptive eligibility is required, so we do that now. I haven't seen the substitute, but the original one extends it and directed us to adopt presumptive eligibility, which would allow other entities outside of hospitals to do it the same. There would also be just time associated with having to set up our systems for the new entities and contracting with the new entities and providing training and things like that. And I'm not, I can't give an exact timeline, but just that would have to be built into the implementation as well.
Well, thank you for that. I'm sure we will be asking for a report, if not formally, informally. This is really important. Are there any other questions? Okay, is there anybody opposed to this bill? I think the presentation was very complete. I'm happy to entertain a motion if we want to move forward with the bill, if it is the will of the committee.
So moved. Second.
Okay, a motion has been made by Senator Suderline and seconded by Senator Bagby to recommend that we report Senate Bill 831. That'll go to our full parent committee. Will the clerk call the roll?
Senator Favola,
Aye.
Senator Suderline,
Yes.
Senator Bagby, Senator Aird.
Aye.
Ayes 4, noes 0.
Very good. Okay, Senator Locke.
Okay, the last bill is Senate Bill 833, and there's also a substitute for this bill.
Yeah.
Would you like to move the substitute?
Please.
Madam Chair, I move the substitute for 833 be adopted.
Second.
Okay. All those in favor signify by saying aye. Aye. Okay, the amendment in the nature of a substitute is before us. Senator Locke, go ahead and explain.
And the substitute had some minor technical changes.
Would you like the general counsel to explain?
Yes.
Okay. Ms.
Thank you,
Bernini?
Madam Chair. The substitute does make several changes, namely, instead of, as in the bill as introduced, directing or permitting the local governing body of the city of Hampton to enter into a contract with the State Board of Health to provide local health services in the city of Hampton, it requires it to do so, and and instead of just provide local health services, it's to operate a district health department that would essentially operate as a separate district health department from the existing Hampton and Peninsula Health District. And also employees of such district health department would be employees of the Department of Health, and the state health commissioner would appoint the local director of the district health department. So rather than permissive, it's required, and rather than just entering into a contract to provide local health services, it's enter into a contract to operate a district health department, essentially staffed by employees of the State Department of Health for the city of Hampton.
Okay, Madam Chair, currently the city of Hampton receives services from Hampton and the Peninsula Health Districts.
I see.
This is a jumbo mega district, essentially two health districts receiving the residents of the cities of Hampton, Newport News, Poquoson, Williamsburg, and the counties of James City and York. During the post-pandemic, the complications and challenges of such a large mega district became evident, with localities having varying needs and challenges. This was recently highlighted in reporting done by the Joint Subcommittee to study the pandemic response and preparedness. The total resident population of these 6 jurisdictions is over 500,000 residents. The residents reside in urban, suburban, and rural environments. Over 50,000 students attend 77 public schools and 5 independent school districts. Within and among jurisdictions, there is significant racial and socioeconomic diversity. Restoring the Hampton Health District as a standalone district would allow the city of Hampton, which is a city population of 137,000 residents, which is nearly 30% of the current mega district, and the Virginia Department of Health to better serve its constituents, thus providing better health outcomes within this area on the peninsula.
I think this makes perfect sense. There may be additional funding needed because it sounds like you're creating a new district, and this has been thought through by your locality.
And we put in a budget amendment to that effect.
Okay, all right. And otherwise, I think the relationship you're looking for is very similar to the current relationships that localities have with the State Department of Health. because you would be obligated to implement all of the requirements the State Department of Health would place on a jurisdiction, on a.
Correct.
Okay, all right. Is there a question I should ask that I haven't asked? Senator Suderline, do you have a question?
I'm only curious if anyone's not for it, but otherwise I'm ready to make a motion unless someone tells us they have a concern we haven't seen yet.
Yeah, let's, is anybody here from the city who wants to just tell us how important this is? That might be helpful.
This is the Assistant City Manager. Yeah.
Hi.
Hi.
Hi. Good afternoon, Madam Chair and members of the
afternoon.
committee. My name is Weeson Walker. I'm the Interim Assistant City Manager for the City of Hampton, and I'm here on behalf of the city in support of this bill. And as you're aware, local health departments are an essential provider of healthcare services for our working poor and others without insurance, as well as providing for our first line of defense and recognition and control of the spread of disease. As such, these departments must be located and managed within our community and ensure access to these and other public health services. Prior to 2017, the Hampton and Peninsula Health Districts were separate entities. Statewide challenges in filling health director positions led VDH to decide to combine leadership of both districts under one health director, and other staff positions were subsequently consolidated. The population of the peninsula, as Senator Locke has mentioned, has grown to over 500,000, with combined district now being a mixed urban-suburban mega district with disparate social economic needs competing for limited health department resources. The negative consequences of this environment was most clearly illustrated during the COVID-19 pandemic. During this period, VDH was fully able to support the Peninsula Vaccination Clinic, which was located at Christopher Newport University, but only able to provide limited support to the Hampton Vaccination Clinic at the Hampton Roads Convention Center. And despite the fact that we actually gave substantially more vaccinations were delivered at that time. So the overarching burden of operating the clinic fell to the City of Hampton operational staff to do it. Right now, VDH operations have also been negatively impacted as the district now lacks stacked redundancy, lacks consistent and stable on-site leadership, and has insufficient staff to engage meaningfully with the public and the stakeholders. However, the fact that the budgets, facilities, and grants for the Hampton and Peninsula Health District departments have continued to be managed separately lends itself to reestablishment of the Hampton Health Department as a standalone district with a dedicated health director and staff. So in summary, as the 8th largest city in the Commonwealth, Hampton needs a fully dedicated health district, which will continue to improve VDH efficiency and benefit our whole region.
Thank you. I think you're probably making the right decision. I just have another off-the-wall question. Do they have to change their city charter or do make any other changes to effectuate the creation of this separate relationship with the health department? I guess this is a question for General Counsel.
Madam Chair, can you clarify the question? You're asking if the City of Hampton would have to implement and establish any additional?
Would they have to do anything with their own city charter or anything?
Madam Chair, I would have to double check. I do not think there's anything significant, particularly because this is a contract with the State Department of Health, and the State Department of Health is who will be providing the employees. They will be employees of the State Department of Health and not the City of Hampton. I will double check and let you know for sure,
Well,
but
just so Senator Locke is completely clear, I don't think.
Because they were separate before and then merged.
And they merged, so I'm wondering
Right.
if you have to do anything else because they're separating again, but you probably do not, and I'm sure your county attorney looked into that. I just raised that question to make sure you're absolutely on a smooth path to making this happen. I don't see anybody in opposition. I think this is a good idea and will serve the residents of Hampton very well. And kudos to you, Senator Locke, for representing your constituents so ably. Would you like to make a motion to recommend reporting?
Move to report.
You have the substitute.
Move to report the substitute.
Yes, that's what we're working on. Okay, motion has been made to report the substitute in a second. Will the clerk call the roll?
Senator Favola,
Aye.
Senator Suderline,
Yes.
Senator Bagby, Senator Aird,
Aye.
Senator Ayes 4, noes 0.
Thank you.
Thank you, Madam Chair.
Senator Locke, have a great rest of the day. So we have one more bill before us.
This was the same thing that happened last.
And it is Senator Stanley's bill, Senate Bill 910, Certificate of Public Need. Oh, it's a pleasure to have you with
Madam
us,
Chair,
Senator
I'm
Stanley.
rocking it with your committees today, and I feel so confident right now. It's good to see you, Madam Chair.
Colleagues, this will be a complicated bill, so I will just
Oh, really?
warn you. We'll just warn you. Not for all of
You've
us.
never lied to me, that's for sure.
That's gonna be my proxy.
Okay.
Madam Chair.
Go ahead. Is there an amendment, or where the
I
bill
know.
that we see is the bill we're going to be acting on?
Nothing I know, but
Okay,
I know
good
no.
enough. Just making sure.
Madam Chair.
Yes.
Members of the committee, Senate Bill 910, of course, is a phased, structured approach to eliminate the Certificate of Public Need, what we call the COPN program requirements that many categories of medical facilities and services in Virginia require in order to, and those things in COPN are required with, whether it's a hospital bed or a PET scan or a CT scan or MRI, any of that kind of equipment, we have a structured way that someone has to apply for it. Really, quite frankly, it was started in the 70s by the federal government, but by 86, they had repealed it because it was anti-competitive. The purposes of it was to encourage the facilitation of medical treatments, and especially in poor areas and rural areas. But in fact, what it did was it created an anti-competitive structure that has limited effect and actually harmful effects in our rural areas and our underserved and inner cities. And quite frankly, it's an old, antiquated system which has to change. And so what this bill proposes to do this in a phased way so that it's not a shock to the system, but rather what we're trying to do is encourage healthcare to be available to everyone throughout the Commonwealth, no matter what your zip code is. It's an anti-competitive, monopolistic kind of section where the government has agreed to create a monopoly and limit competition with the promise, and it's kind of a quid pro quo, that in response, the hospital or the provider will then supposedly provide care and bring down healthcare costs and provide care in our inner cities and rural areas, when in fact they don't. Ladies and gentlemen, and Madam Chair, I would say that where I live, there are many people that live on top of mountains that have to drive 150 miles to go to get an MRI, or have to go to the state of North Carolina because we don't have health care available to them, modern health care. And unfortunately, because of your zip code, those that are living in the more affluent areas of our state, Northern Virginia, that have hospitals around the corner, are in contrast to areas in Southwest and Southside Virginia where the hospital may be in West Virginia, Kentucky, or North Carolina that's accessible to them. Right now, what we're seeing is that the hospitals per 100,000 Virginians has gone to, that there is less than, it's about 1.1, 1.2 hospitals per 100,000 people in the Commonwealth of Virginia. That should be an alarm bell for all of us that the system that we have in place is not working. And that CON, that Certificate of Need, like many states that are dropping it now, only 35 states have it, are finding that they're, with competition, that brings down healthcare costs, and it also increases access where access is needed the most. That your economic position does not matter, and that the healthcare is the same because there's competition, and that we in the rural areas and the inner cities are not getting less healthcare or a lower quality of healthcare, but quite frankly, because of competition, we're getting the same type of healthcare that they get in the more affluent areas of the Commonwealth of Virginia. This is something, quite frankly, that its time has come and the discussion needs to be had. This will enhance access to care. This bill will streamline facility development, improves rural healthcare access, as I've said, and also inner city healthcare access. It encourages competition. In the free market system, I don't know that we have to create monopolies and, at the same time, grant special privileges as a government to one set of healthcare providers and limit it or restrict it from others, because in the end, that drives up healthcare costs. The purposes of CON were to drive down healthcare and improve access. What we've seen is this COPN has driven up costs and has not driven down costs, and it has not improved access because now these areas are spread out instead of having accessibility right around the corner, as we should. This will, if we repeal in the structured three-tiered system, we will reduce bureaucratic burdens. We simplify the regulatory framework. Because right now, I don't know if you know, but you get calls from people that are making an application for an MRI or something, and they want your support. You, a senator or a House of Delegate member, has to write a letter of support saying, we need this MRI. And instead, it should be the competition that dictates where that MRI is, because obviously it will flow where competition then creates the ability to have more of them in more places that need them. This will also support modernization and innovation by encouraging technological investment in areas in our inner cities and rural areas that right now are cut off by this. It facilitates also facility upgrades because you know what? If there's competition, then I want to have the most up-to-date PET scan. If I'm in competition with another PET scan or an area in that area, you're going to want to have the best healthcare to make sure that you're serving the most people. And yet, I don't want to call them clients or customers, but your patients are going to go. They're going to get the most modern testing equipment available. States are leaving COPN. We should have market-driven healthcare. We provide government healthcare, but when it comes to these and having the accessibility, we should also have market-driven healthcare. And that way, we're aligning ourselves with a broader shift towards solutions that better respond to patient demands and demographic shifts. We need to safeguard our vulnerable populations. Nursing homes, specialized care centers, as I said again, rural areas and our inner cities have more in common than we do not in common. We all have higher chronic diseases rates. We also have lower numbers of doctors. Our doctors are older, and when they leave the profession, they're not being replaced. For every 2 doctors that leave, we're getting maybe 1 back in the rural area, and the same as in the inner cities. What we have is a need to create a competitive place for these testing centers that can detect disease early and fight them and give people a higher quality of life and a better chance at life when these diseases or these problems are detected by this equipment, which so far now, if I want to get a PET scan, I got to go to Lynchburg or Roanoke. Shout out to Roanoke. But why is that? Why does my 84-year-old mother, have to take a 90-minute trip or a 60-minute trip, or anybody's mother? It's not right. And we need to make sure that we do this the right way. That's why this bill provides for gradual implementation. So, Madam Chair, members of this committee, this bill in its form represents a balanced and forward-thinking approach to reforming healthcare regulation in Virginia. If we eliminate through this phased process, our state, our Commonwealth, will be able to enhance the access to health care, foster competition and innovation, reduce regulatory burdens, align with the national best practices, and maintain safeguards for our vulnerable populations. This bill provides a smooth and deliberate transition benefits the patients, providers, and the broader healthcare system in Virginia. And Madam Chair, that is the bill, and I apologize for my passion, but we are suffering in rural Virginia and our inner cities, and it needs to change. It's not working.
Yes, and I do understand the situation that you presented, and you presented it with passion and great concern for your constituents, and I do understand that healthcare is not equally accessible across the Commonwealth, that we don't have resources in places we need them. And you pointed out some problems which absolutely have to be addressed. There's no question they have to be addressed. I'm not convinced that this proposal is the proposal that's going to fix the problems you just laid out.
And Madam Chair, with all due respect, and I respect you greatly, you know that, when are we going to stop talking about it? When are we going to do something about it? We've talked about it enough. Who is this going to hurt?
I actually think we have to enhance our telehealth and the allocation of some of our professionals who have received actually grants and scholarships to become healthcare professionals. Some of those actually do have a requirement that they practice in underserved areas. I mean, there are ways we can provide services. I just want to make sure that whatever hospitals you have in that area can thrive. And I do understand that part of the reason and part of the calculation of allowing them to thrive in providing a range of services is the COPN has been an element where they could perhaps make a little bit of money on some of these more direct and less complicated procedures, and then they can support the more complicated procedures like a NICU unit or heart surgery or other things that are very expensive and the patient is not charged the full cost. So the provision of health care is very complicated and it can be very expensive. Did you bring speakers here to bolster your argument? I think I've got some speakers in the audience that will probably want to enlighten us even further.
Madam Chair, I did not specifically ask, but there may be those that support the bill, and I'm sure that there are those that oppose the bill from the hospital
I
industry.
am sure as well. Okay, for those who support the bill, please keep your remarks to 2 minutes or less. We are going to put you on a timer, and these would be proponents of the bill. We're also going to hear from those who would be in opposition to the bill. Yes,
Madam Chair, Benjamin Knotts with Americans for Prosperity. I want to highlight that the Commonwealth of Pennsylvania is very similar to Virginia in how it's built out with the demographics in the cities. What we see is very plain. When they repealed CON there, none of the sky is falling happened. They actually have more ambulances, more hospital beds, and more services. So I really encourage you to consider this. It gives them plenty of time. And to the RPM comment, UVA has shown that RPM is going to limit more and more ER readmissions because you're keeping people from having to go back to the ER, which was the whole justification for COPN was ER traffic. So I encourage you to look at this because the future is out there. COPN's a past. The Obama administration said get rid of it. The Trump administration said get rid of it. And y'all need to get rid of it. Thank you.
yes, sir.
Hello, Senators. My name is Caleb Taylor. I'm with the Virginia Institute Action and also very much in support of the bill. There are now over 100 pieces of independent research along these lines. We have an amazing amount of data on this particular policy. And essentially all of these independent pieces of research show that COPN does the opposite of what it was attempting to accomplish. And I would just please consider this step forward into removing the, I don't know the best way to put it, I guess the corporate welfare for hospitals, however you want to place it. But it is, please just consider the idea of just getting rid of this problem.
We have had several studies. We had appropriation language 4 years ago. We actually had a bill a couple years ago. And I don't know if our general counsel has had access to that, to those studies, but as far as I know, we haven't ever received a full report. Is that correct, Ms. Dime? I'm asking Julie Dime with the Virginia Health and Hospital Association.
Madam Chair, Julie Dime with the Virginia Hospital and Healthcare Association. I am going to punt to my colleague Brett Rawlings, who has been very actively involved in the task force that you're speaking of.
If you don't mind, committee, I think we should get an update on what the studies have been.
One real quick.
Senator Suderline.
I expect they're going to provide lots of good information. I just want to make sure that the gentleman who is at the podium has finished his comments. And then I think there's another gentleman standing next to Senator Stanley.
Yes.
So if we want to finish the
those
affirmative on
proponents.
this position, and then we'll hear from folks that have concerns.
The only thing I would say,
rather than getting a running debate. That's just my
Well,
thought.
yeah, it wasn't going to be a running debate. I just wanted to know if the reports have actually been issued, was my question. Multiple reports.
alongside those reports, I would recommend there is a amazing piece of legislation. It's on the brain. Amazing piece of research out of the Knee Center, West Virginia University, that has studied that it is essentially bringing in every piece of research that's been done independently on certificate of need in the entire country, and would strongly recommend taking a look at it. Would be happy to bring a copy of that to y'all's offices at your leisure.
Okay, thank you. Yes, the Medical Society of Virginia.
Clark Barano, Medical Society of Virginia. If there's anything we agree on COPN with the hospitals is that we do not need another work group or study, please. We would appreciate that very much.
Yeah, I understand.
One thing I would offer is recently we were asked, what is our strategy around COPN? Whether this is the vehicle you all decide to pursue or not, the winners are going to keep winning and the big guys are going to keep getting bigger in Virginia. To that end, I was texted recently by an ophthalmologist here in Virginia, and he said, I'm just reading my text, I apologize. Just a heads up, the last ASC in my town was recently bought by a large hospital system, the only surgical center, and they're not allowing any community ophthalmologists to get on staff. There's a 6-month wait for cataract surgery in our town. I don't know what to tell my patients. That is the reality of COPN. The big guys are going to keep getting bigger. The winners are going to keep winning. So whether it's this vehicle or the work through the task force, I know eventually the dam's going to break. And so we appreciate Senator Stanley for trying to find some way through. And we respect the remarks of Senator Favola today, because I do think you have a good line of sight on this issue. And we respect our friend Mr. Rawlings, who's going to talk to you a lot about studies and task forces. But
Actually set up satellite centers to provide some of those less complicated procedures like colonoscopy centers and such.
They do. And all of those centers
Sort of
charge a
standalone
facility
centers.
fee that is more expensive than an independent ASC, which increases cost for patients. So you're absolutely correct.
Again, I really appreciate your comments. We will have a robust debate on this. Okay, I'm going to ask for those who would like to speak in opposition to the bill. You two will have 2 minutes.
Yeah, that's fine. And Madam Chair, members of the subcommittee, Brent Rawlings, Virginia Hospital and Healthcare Association. We're opposed to the legislation as we've been opposed to this legislation previously introduced. This is not the first time we've seen a phased deregulation bill. There was one filed last year. There was one filed in 2018. This has been before the General Assembly time and again, and it's been rejected time and again because through these multiple work groups from 2015 through 2019 and beyond, we've all agreed that COPN should be retained in Virginia and reformed and improved. We acknowledge that, and that's the work that's underway as a result of a bill that passed in 2020. We certainly sympathize with the senator and the needs of all Virginians to have access to health care, particularly in rural and underserved areas. But the reality is that eliminating COPN will not fix that. In fact, we think it will have the opposite effect. Just to be clear what this bill does, it eliminates COPN completely. It'll be gone in 2 years. That's very significant. As you've heard from us, COPN is important for us. It helps us to maintain financial sustainability and provide essential health services across the Commonwealth. The reality here is a lot of talk about free market. We don't operate in a free market. This is not a free market. There's not competition for underserved areas. There's not competition for rural areas. There's not competition for uncompensated care. And that's the reality. Any doctor, any group that wants to go in a rural area and open a facility, open a diagnostic imaging center, they're going to get a COPN. COPN is not the problem. The reality is there's 28 rural hospitals in Virginia. Of those 28 hospitals, 26 are owned by health systems as a result of consolidation. The reality is those health systems are being subsidized, or those hospitals are being subsidized by that larger healthcare delivery system, which is all backed and supported by COPN. The reality is that our biggest challenge is workforce in these areas. That's a conversation we need to have. So we're committed to doing the work to get access to healthcare across the Commonwealth, but this is just going to set us further back, so we're opposed.
I just want to, again, emphasize to my colleagues that we have studied this at great length, and one of the factors that the study teams were charged to consider was improving access and ensuring that those without insurance or those who are underinsured, which picks up our Medicaid population and other populations, still have access to care. And the COPN framework does require that these individuals be served, and that is a big deal when it comes to equitable access. Is there anybody else in the audience who wants to speak in opposition, or did Mr. Rawlings speak for the hospital providers? Mr. Rawlings spoke for the hospital providers? Okay. There's one more person.
So Beth O'Connor, Virginia Rural Health Association, neither for or against, but more on the fence, wanting to see some major changes. Senator Stanley very correctly pointed out, we have big gaps in rural health care, and we would like to see some streamlining where there is obvious need. We're trying to get a hospital reopened in Patrick County. Their requirements for meeting COPN should be greatly reduced. Many of our rural areas do not have any sort of prenatal care, labor and delivery services, maternal health services. Right. Those paperwork requirements should be greatly reduced. We have some concerns with getting rid of COPN overall, but we would like to see a streamlined process. Thank you.
Thank you, and I really appreciate your measured comments. You seem to hit a lot of themes that are very important. 2 years ago, we set up a work group to look at rural health, and I have not yet received a report. Has anybody received a report on the rural health work group? I guess I'll ask General Counsel, Julia, have we received a report from the rural health work group?
Madam Chair, Madam Chair, I am checking right now, and I will let you know in about.
So
I can fill the time if you'd like.
No, you can't. I am sure you can fill the time, but you would wear me out, Senator. Let me give Senator Stanley some advice because he did identify a very important problem. Senator Stanley, I want you to read the report from the Rural Health Committee. They were charged with improving access to care in rural health areas, recommending some changes in our system so you can have an area that is flourishing with access. And I think we need to look at the rural health system perhaps a little differently, separately.
Speaker Don Scott has actually commissioned a group to investigate this as well, and he's come through our area, and we're very grateful. I think, much in the same way that you, Madam Chair, and I looked at the disparity in school modernization in inner cities and our rural areas, they undertook that. But ultimately, I think what you just heard from the representative from the Rural Health Association is true. Women have to drive hundreds of miles because, pregnancy and delivery care is not available. This is not right.
No, it's not.
And I don't care what they say. Hospitals are far and in between great spaces before people can reach them. And, we have one in Martinsville. We want to have one in Danville, but you go west a little bit and you got to hit Bristol by the time you see another one. So after Roanoke. So it's where you see one at every corner. Here in Richmond, we don't have that. And quite frankly, if we do nothing, then we continue to talk about it. We do reports about reports and have meetings about meetings. And quite frankly, it's not a shock to the system. In other states that have done that, Madam Chair, that have repealed CON, have found that it increases competition, it has lowered prices, and what it really does is increase, with that competition, access. And that's the key we should all be concerned about, because we're representing every Virginian when we come here, not just the people in our area.
Madam Chair. I want to thank Senator Stanley for bringing this bill forward. I certainly hear the passion in his voice, and as someone who also represents a number of rural localities, I can certainly understand both why he brought this forward and the sense of urgency that exists with finding a real solution to this challenge. I think I've officially been elected long enough to say we have been talking about COPN, CON for quite some time, and so I also share the desire to want to finally come to a recommendation that we can move forward. Having said that, I think I also echo the sentiments of the chairwoman in saying that while we do need a solution, this seems to require some additional work, some additional conversation, and hopefully with the work that the Select Committee is doing in the House on rural health care, as well as the rural work group that I believe is being researched right now, perhaps we can come to use those recommendations to once and for all find a solution to this. And so, Madam Chair, having said that, I'm going to ask that we gently lay this bill on the table.
House?
PBI.
Thank you, Senator Aird, and thank you for the second. Senator Bagby. You may speak to the motion, but then I'm going to ask General Counsel. She has some information here.
Do you want to provide that first?
Madam Chair, the Select Committee on Advancing Rural and Small Town Healthcare did issue and publish its final report as of December 15th, 2024. It's fairly recent, but it is out there, and you can find it on LIS on the Reports to General Assembly website.
Well, I thank you, because that may bolster the intent and the motion that's before us. I think we need to study that report and perhaps come up with a bipartisan approach to really helping the rural parts of our state. Senator Suderline.
Thank you, Madam Chair. I appreciate Senator Stanley bringing the bill before us. If it was a motion to report, I wouldn't be voting for that, but I'm going to be voting against the motion to PBI just because I think that there needs to be more discussion. I don't think the bill, as the way it's currently formulated, I do disagree. It would be a shock to the system. I think several proponents want a shock to the system. But I have some concerns about how it would be structured. I also think that it's incredibly important how we talk about it. Senator Aird made reference to this too. When I ran for the first time in 2015, the adjacent district, this was one of the big issues in it. And the challenger ran on complete repeal of COPN, and the incumbent was reelected, and the incumbent just left office last year. And by the time he left office, he was for complete repeal. And I think this is one of the few issues where people, the longer they're in the General Assembly, they get more frustrated with it and even more concerned about the status quo and how it's going. A lot of you remember I spent a decade, which shouldn't have taken that long, trying to bring a neonatal intensive care unit to Salem, and several folks here were supportive of that. I appreciate it, but the COPN process, wasn't working for so long, and it took a decade for it to work out. And so I'm not going to vote to PBI the bill because that means it's done. No, I'm going to vote no.
Madam
for
Chair, I'm
PBI.
happy to withdraw my motion.
But
Madam Chair, motion to report. Move to report.
Did you withdraw your motion? Okay.
Move to report.
Motion has been made to report the bill. Is there a second?
Second.
Okay, a motion has been made to report the bill, and it has been seconded. Any further comments or debate on the motion?
Thank you.
Senator Durant.
Thank you, Madam Chair. Forgive me, Senator Stanley, I came in right toward the end of it, so I felt like I was catching half of this debate and discussion. I would like to see us continue, because I'm hearing you loud and clear, and I know that there's really healthy debate going back and forth, but I sense a great deal of frustration throughout, it seems like, your district and beyond, that they're just not getting the care they need. So I'm not sure, I can probably see where this is going to land, but that doesn't mean I want it to end right here in this committee. So I'm going to support it.
Thank you.
Okay, will the clerk call the roll? This is on a motion to recommend report to the full committee.
Senator Favola?
No.
Senator Suderline?
No.
Senator Bagby?
No.
Senator Aird? No. Senator Durant? Yes. Noes 4, ayes 1.
Thank you.
Okay, that motion fails, but
Thank you, Madam Chair.
I will ask anything further that this committee needs to address at this moment.
No, Madam Chair, that concludes the docket.
Thank you. The committee shall rise.
Thank you, sir.
The Senate of Virginia, Richmond, Virginia.